I'm going to be talking about screening for lung cancer today, and I don't know how far along Australia is in screening that. You actually do have some publications and some interest in screening, and what I like people to do when they think about screening, though, what I'd like you to start with is before you put on your medical hat, before you do that, I want you to think about yourself as a family member or as a partner of someone, a spouse, or as a child of someone. Because I guarantee you have feelings about screening. You know, whether mom should get a mammography, whether your wife should have a mammography, or your husband should have their prostate checked. And I can tell you that screening's a relatively new science. You know, we hear about these things that we talk about prevention. For example, an apple a day keeps the doctor away. You know, that wasn't meant for screening. That was actually a Welch apple farmer trying to sell product in the 1800s. And so screening is a relatively new science, and I think it behooves us to be very careful about how we think about screening. Here are my disclosures. None of those are for consulting. They're all research grants to the institution, and I don't do any paid talks or have any consulting engagements. So about, I guess it's a little over 13 years ago, several colleagues of mine at Dartmouth did this sort of general population attitudes towards cancer screening in the United States. And I guarantee you it's not much different in Australia. And they interviewed 500 people. 87% thought that screening was always a good idea. 74% believe that finding cancer early saves lives most or all of the time. And less than a third believe that there will be a time when they stop routine screening, no matter what their age. A substantial proportion believe that if an 80-year-old didn't get screened, they chose not to be screened, they were being irresponsible. How about that? 38%, and I'm actually included in this group, my wife had a false positive breast cancer screening, had a false positive. 40% of those said it was the scariest experience of their lives, and I actually would agree with that, and yet 98% were still happy that they had done the test. We are, as humankind, we've bought into early detection and diagnosis for sure. 2/3 thought they should be screened even if nothing could be done. So imagine that, sir, you have the mad cow. You're going to die in about 6 weeks. Can't do anything. Well, thanks, doc. I'm glad I knew about that coming up. 73% said they would prefer $1,000 a total body CT screen as opposed to $1,000 in cash. I can tell you where I come from in Charleston, South Carolina, we'd all take the money, go to a bar, light up a cigarette, and buy everybody else a drink if we got $1,000. We wouldn't take the $1,000 in cash. Are physicians any different? And this is a study of primary care physicians' recommendation of mammography for terminally ill. This is almost 1,200 primary care providers, and they surveyed them with hypothetical patients with varied ages and comorbidities. And almost half, how about this? Almost half would recommend mammography to a woman aged 50, 65, or 80 with terminal lung cancer. What does that tell you about where we're at as physicians and where the population is at about screening? It's a very, very interesting thing. And so and I hope at the end of this talk you won't say that Dr. Silvestri doesn't want you to be screened. We have an active screening program. I think people just need to be pretty thoughtful about how they do it. So just to get into this for a second, I do want to talk about something called overdiagnosis. And so there's a cancer cell, and one with a very heavy tumor biology, and up there the red line shows where cancer might cause death. There's people with different biology, and you can see that it takes a little longer for them to die. And there's people with even different biology, and those are people that no matter what you do, cancer was never going to be the cause of death, something else was. So there's the size at which cancer is detectable by screening. And if you do an annual screen, you'll see something pretty interesting, right? This group here wouldn't have been helped by screening. Their tumor grew so rapidly that it bypassed screening. This group would benefit from screening, and this group of indolent cancers would never have been benefited from screening. And in fact, the only thing they can get from screening is harm. This group right here. The only thing you can do is hurt those individuals. So there's its life-saving, and this is overdiagnosis type 1, which leads to unnecessary treatment. And if you think that never happens in lung cancer, in fact, it looks like about 15% of the lung cancers picked up in the National Lung Screening Trial were overdiagnosed. They were excess cancers not seen in the control group of nearly 50,000 people. So there's another type of problem of overdiagnosis, and that's one where you get diagnosed okay, somewhere in here, but the treatment causes you to die. And that's something we don't often think about, right? Have a patient who has a solitary pulmonary nodule in the middle of that 2-liter Coke bottle that is our lung. It's pea-sized, it's right in the center. Patient gets operated on, has it resected. By the way, it turns out it was benign. That happens. And then the patient ends up in the ICU, post-op complications. They get trached, they get pegged. They end up dying 6 months later. And that was they don't put on the death certificate, that was a screening complication, right? It's respiratory failure. It's not a screening complication, so something to keep in mind. So what are the principles of screening? We want to diagnose disease in asymptomatic patients. You want to detect disease that will respond better to early treatment instead of late treatment. That does seem like it is for lung cancer, early stage, treatment with surgery, they do pretty well. And you need to provide the benefits in treating the small number of people who will be diagnosed with the disease, and that has to outweigh the harms with associating with screening a large number of healthy individuals. Remember, people aren't coming to ask us for our help, like when they have a COPD exacerbation. You're searching for disease in a relatively healthy population. Totally different conceptually, I think. So how did this all start? Well, there was the National Lung Screening Trial, we were involved in that trial. We enrolled about 700 patients. 33 centers across the United States, 53,000 patients, so it's the largest screening trial for a single disease state in one trial. Low-dose CT versus chest x-ray. We know chest x-rays don't work, by the way, yet in the United States, people still use them for screening. Patients had to be asymptomatic. It's a very interesting concept here, which I'll get into later. Age 55 to 74. 30-pack year history of smoking. If they were a former smoker, they had to have quit within the last 15 years. If you quit late, 16 or 18 or 20 years ago, your risk of lung cancer was so low they didn't think you needed to be in the trial. No prior history of cancer, and no CT in the last 18 months. And you can see that the trial was actually stopped early, and it had both a reduction in lung cancer mortality and a reduction in overall mortality. The reduction in lung cancer-specific mortality was 20%, and overall mortality was about 7%. And of that 7%, most of it was the reduction of lung cancer that reduced the overall mortality, though some people they picked up a aortic aneurysm or a renal cell cancer and were able to resect those. God knows what we're going to do with all these thyroid nodules we're now finding. This is one of the things that sort of downsides, right? If you're going to have someone be screened who fits those criteria, what you can tell your patients is about a quarter of them will have some type of nodule. Of those, the vast majority are going to be benign, okay? One of the things you should also tell them is, even if you're screened, not everyone doesn't die of lung cancer, right? So there were 356 lung cancer deaths in the screening group and 443 in the chest x-ray group. These are those people I talked about. Cat got out of the barn faster than screening would have picked it up. And I think I told you about this. By the way, a later study by Paul Pinsky, after Denny Aberle published the initial trial, showed that this relative risk reduction in longer-term follow-up was probably only about 16%. There are 4 other trials going on in Europe, and the biggest one actually still hasn't reported its results. 4 trials with 12,000 patients, which were randomized to LDCT, and usual care. They didn't have chest x-rays. One trial randomized patients to having a scan every 2 years. None of those showed any benefit, but they actually say in the methods section of their trials that we understand that this is not powered to see a benefit, but what we're hoping to do is put together all of the European trials into a meta-analysis. Kind of a little sketchy in my view, but okay. The Nelson trial, which is powered, almost 16,000 patients, a little bit different criteria. They were a little younger, could smoke a little bit less, but had to quit within 10 years, and they did 1, 3, and 5 years CTs. Still haven't reported the data from Nelson. A little bit worried because the study's been done for a while, and I think what they may be doing is putting these patients together with these patients to see if there's a benefit. This is about to come out in the journal Chest. Peter Mazzone, myself, and some others updated the guidelines for lung cancer. And you can see that here's the 53,000. This is the study, very tight confidence intervals. You can see here that there's benefit on this side. But here's those 4 studies with 12,000. The line crosses 1 showing no benefit. And of course, Nelson hasn't reported yet at all. So this number of patients overwhelms all of these other groups combined, but I think it's important because Europe is not screening as of yet, and I think they're waiting to see what happens with the Nelson and other European trials. So in our country, the U.S. Preventive Services Task Force recommended screening for what happened here. They actually did some modeling and went up to 80 because they said, look, 74-year-olds had CTs, and for the next 3 years that they got their follow-up CT, and they still were finding the same number of cancers. The Center for Medicare and Medicaid Services, that's sort of our national health system for the elderly, kind of split the difference, and I ended up having to testify before them for screening coverage, and I don't know why, but they were like, well, 74, 80, we're going to split the difference, and they went with 77. So that's what gets covered in the United States, 55 to 77. What's happened since NLST? Published in 2011, and our lab's been really interested in a lot of these things. One of the things that I was very concerned about is assessing the generalizability of the lung screening trial, personalizing the choice, helping identify those who may gain the most benefit. I didn't include those in these slides, but we did a cost-efficacy analysis, assessing the differences by race and assessing whether smoking abstinence might help, and then finally looking at comorbidities and age and screening. So let me show you some of that work. So this is the demographics in the National Lung Screening Trial, the male-female ratio. These are the age splits. One of the things you should notice right away, average age of onset of lung cancer is 70 in the United States. And really, we didn't include that many elderly patients in here. Percentage of African Americans was very low. Our population is almost 11%. So, and they were actually really well educated. So younger patients, really well educated. We looked at, not we, but they did a survey, looked at our national data sets on what would smoking rates and age might fit the criteria for lung cancer screening in the United States. It turned out it's about 8 million people in the United States fit that criteria. Let's take a look at those. So if we take a look at those, 4 things jump out. First of all, they're a lot younger in the NLST, which may mean they do better with all sorts of treatments, right? So almost double the number of elderly patients in the general population. More current smokers, which is actually a good thing for screening because you're more likely to pick up a cancer, and less, about half, is educated. And again, education in the United States, anyway, has a little bit to do with access to health care, wealth, and access to a primary care provider. It may not be the same in Australia, but certainly that way in the United States. So I wanted to keep an eye on all these things. The other thing that was a little bit different in this trial was that most of the patients were enrolled in urban tertiary care hospitals, large academic medical centers, expertise in all aspects of cancer care. In fact, 76% of the patients enrolled in this trial were in what we call the National Cancer Institute's designated cancer center, of which there was only 60 in the United States. So they're not everywhere, and we're one of them. And so all of our radiologists were dedicated chest radiologists. They can tell the difference between an intrapulmonary lymph node and a true pulmonary nodule. And recommendations for follow-up were made by these radiologists. Now, they could get the recommended care in the community. We didn't force them to have it done at these centers. The problem is that when you have a nodule that's detected at one of these centers, you're probably going to come back to that center, and all of the surgeries done at our institution, all the people who had a nodule that eventually was resected as a cancer came back to our place for it because we had a dedicated thoracic surgeon who would do it under VATS surgery. So, a little bit different. We don't know whether this will translate out into the community. So if you look then at complications of invasive procedures, if we look at all the trials, 17 CT studies, what we see is that there's about a 5.1% complication rate, but that rate varies, and this includes the European trials and the American trials, tenfold. Less than 1% in sort of the high-end academic centers and 7% in smaller community settings. Major complications, pretty rare, but in the CT surgery center, 7.8 per 1,000 screens. If you look at death, and you shouldn't really die from a screening test, right? That'd be bad form. What we see is 0.8% or 6 per 10,000 screens. Actually quite acceptable until you're, the one on the, this side of that 0.8%. So what about surgical mortality? This has kind of always bothered me a little bit, but we'd studied it in the past. The National Lung Screening Trial had a 1% death rate from surgery, right? And I can tell you, as soon as I read, we were part of the team, but as soon as I read that and read the article, I went immediately to the literature and said, wait a second, man, there is no there's nothing in the thoracic literature, the thoracic surgery literature, that you will ever find that's 1%. And if you look at our national databases, they're 3 to 5%. We know a couple things about that. If you have your surgery in a high volume center or a dedicated thoracic surgeon, this is work we did and Peter Bach at Memorial Sloan Kettering, you're going to have better outcomes. There's just no question about it. In fact, mortality, if you have your surgery done by a dedicated thoracic surgeon, is half as high as if you have it done by a general surgeon. If you're in a high-volume center, 100 cases or more a year, your 5-year outcome is twice as good as if you're in a smaller center. It just makes sense. You know, practice makes perfect. And it's not just the surgeon, right? They have better ICUs, better respiratory care, better care plans, et cetera. So I put together this little chart here, and look, I put our 1% up here with 660 surgeries in NLST. But you know, I'm a big believer in large database and general health outcomes. If you look here, 512,000 cases, about 5%. This is from the Surgical Thoracic Society. These are dedicated thoracic surgeons who are largely at academic medical centers that put into a database about 2.5%. And then the Dante trial, which is the only other screening trial that's reported mortality, not 1%. Our Italian colleagues have about a 3% mortality. And again, that might wipe out some of the benefit of screening. You know, I show this slide. Are any thoracic surgeons in the room? Good, because then I can make this joke. I would make it anyway. You know, whenever I show this at given grand rounds or something, a thoracic surgeon raises his hand and he says, "Not at my institution. This is ridiculous. At our institution, there's only 1%, and I can show you our data." And they slam their hand down. And I go, you know, I've heard that at every single place I've ever lectured. And you know what? I'm just waiting for the one time I show up and a thoracic surgeon raises his hand and says, you know, everybody dies at my institution. Not one person lives. I am the typhoid Mary of thoracic surgery because somebody's dying somewhere. It's just never anywhere that I go. So I'm still waiting for that guy to turn up. But I think probably if you're talking to patients, you probably ought to say between 3 and 5% mortality. That's probably the honest answer, right? And then there's this whole idea of surgeries for benign disease. Remember, a quarter of these people are going to have nodules. And if we look at the CT studies, the rate of surgery, 1 in 5 are going to have a nodule resected for benign disease. You know, some of those people aren't going to do so well. The range was actually 10 to 40%. And I'm not going to talk about it today, but in another life, that's sort of my life's work, is to helping doctors differentiate between benign nodules and malignant nodules. And so the absolute rate of surgeries for benign disease in the 17 CT studies was 4.5 per 1,000 people screened. I just want to show you this study that my lab published through in CHEST. Nicole Tanner, my junior faculty, was the lead author. And this was a study that we published in CHEST, I think in 2015, where we were able to get a hold of close to 400 medical records of community hospital pulmonologists throughout the United States, and 2 years worth of data, so we could follow the sort of that diagnostic odyssey of pulmonary nodules. And what we found was pretty interesting. We took every single patient and we put them into a risk calculator. Were they low risk probability for cancer? Were they intermediate risk, or were they high risk? Low risk you follow with, you just go ahead and follow with serial CT. Intermediate risk, biopsy or PET, and high risk, straight to surgery. And actually, so these are the groups, 300 in the middle, 36 on the front end, 41 on the back end. And what we saw was that the actual models worked pretty well. Here you had nobody in that low prediction group had cancer, a bunch of people in the high prediction group had cancer. But look at this. If you look at the rates of surgery for patients, they were exactly the same. So doctors were not like, now of course, we don't know if they did this calculation, but we do know that doctors are intuitively very good at predicting whether a nodule is cancer or not. Problem is they don't follow guidelines. Surveillance rates did increase, and did decrease, as the risk went up, and biopsy rates did increase, but they were not statistically significant. We got to get better at this if we're going to do screening. So surgery for benign disease, by the way, in this study of community pulmonologists was a whopping 35%. It's kind of crazy, right? All right, I want to get into individualizing risk. This is an area, like, if you're going to get into screening, and I do hope that some people take on that task because I think it can help people. What I'd rather have you do, rather than screen patients just by broad categories, 55-year-old, 30-pack year history smoking, I'd rather you use Martin Tamimagi. This is a group of, I'm telling you, I know this is going to sound shocking. This is a group of tremendous geeks. I mean, these people live and die for making models and stuff. And this is a selection criteria for lung cancer screening published in the journal in 2013. And what Martin did was he took a bunch of other predictors. These can all go into, it's called the Brock calculator. That's the university he works at in Canada. You can plug this in like 2 seconds. And what it does is give you the risk of developing cancer in the next 6 years, okay? So you can imagine that, and so with that, by the way, we tested it on a group of people from the NLST criteria, and what we found was that the sensitivity was better without losing specificity, more patients were discovered, and the area under the curve was better. So this is the model right here, and you can go online and fill that in. I want to put it into some context for you, though. This is another nomogram. You take 5 minutes. You plug this in the computer from Sloan Kettering. This is Peter Bach's work. Let's take a 55-year-old woman who had a 30-pack years. That's what you need to get screened, right? But had smoked for 30 years, had 20 cigarettes a day, so a pack a day, and she had not quit smoking, right? Over the next 10 years, if you do not quit smoking, your risk of developing cancer is 1%. And if you continue to smoke, it's 2%. Now, that's a completely different conversation than this next patient I'm going to show you. Next patient's a bit older, 70 years old. Number of cigarettes, number of years you smoke, 55 years. 2 packs a day. In the next 10 years, this gentleman's going to, if he quits smoking today, is going to have a 13% chance of developing cancer. If he keeps smoking, almost a 1 in 5 of people like him will develop cancer, right? Both are eligible to be screened. I'm not denying screening of either one. But to me, like this guy, you might want to sort of think, I should be screened. The other patient may develop harm more than good. Taking this information into account, we got the band back together, and again, group of tremendous geeks, and what we did was we started to look within the National Lung Screening Trial data using Martin Tamagi's model to break it up into these are people who all made criteria for the screening trial, which was a positive trial, said let's look at this by quintiles of risk of developing cancer and see what happens. And so we divided the participants into 5 groups by risk. Quintile 1, the lowest risk, quintile 5, the highest risk, and we looked at the number of deaths from cancer. What we found was 2 really important things. The first thing was, if you look at the lowest quintile of risk, what you saw was these are the number of lung cancer cases, very few in that lowest quintile risk. Look at the number of false positives per prevented lung cancer case. If you look at the lowest quintile risk, almost 1,600 false positives, and the number needed to screen was 5,000 to save 1 lung cancer. Now, in the overall trial, the number needed to screen is 300. For every 300 screens, you're going to prevent a cancer death. That's about the equivalent, by the way, of mammography for breast cancer. So that's cool, right? But look at this. If you go by quintiles of risk, this is only, you have to screen 5,000, as opposed to look at these higher quintiles of risk, very few false positives, and very few numbers needed to screen to prevent a cancer death. If you're a health policy person, if you're a health policy person, you might look at something and go, uh-oh, 60% at the highest risk, so the 3 highest quintiles, accounted for 88% of the mortality reduction. The bottom 20% only accounted for 1% of the mortality reduction, and they had the highest number of false positives, which could lead to harm. So if you're a policy person, you're like, look, we're not like in the United States, we never do this. We just keep going further and further into debt. But if you looked at this, you'd go, wait a second, man. Like, I'm sorry, but that lowest quintile from a health policy perspective, we're going to help you quit smoking, but we're not going to screen, right? Like, that would make a lot of, I'm not saying we'll do that, but that would make a lot of sense. But at the very least, patients should know their individualized risks, so at least they can make an informed decision about which way to go here. What else have we looked at? Paul Pinsky at the cancer thing looked at demographic differences, and he found that the benefit did not vary by age. The overall mortality reduction was really more significant in women. And how about this? If you took women out of that trial, it would have been a negative trial. So women do seem to have more of a benefit from lung cancer screening. We have no idea why than do men. He also looked at the elderly population. I'm going to show you more data about that later, and found two things that are interesting. One is false positives are higher in the elderly. That's important, right? Wear and tear on the lungs. We know that when we get CTs of elderly patients, you see more things. That's problematic because then they have more invasive procedures in a group that's more fragile, right? Complication and resection rates were similar, although, and remember, this was done at high-volume centers. But here's was an interesting thing, caught my eye and led me to another study I'm going to show you in a second. 5-year all-cause survival was lower in this group. Why? Elderly people have competing causes of death, COPD, heart disease, and all kinds of things, aortic aneurysms, et cetera. So there was also no difference between current and former smokers, although you had to screen a lot more former smokers to find a cancer. Squamous cell didn't do as well, right? There's no benefit if they had squamous cell. Of course, you can't know that before you screen, so I'm not sure what that added to the medical literature. Robert Young, this is a fellow from New Zealand, also looked at a subgroup of patients with COPD and found that they had an increased incidence of lung cancer and a more favorable stage shift. And so this is, remember that if you have COPD, you're 3 to 6 times more likely to develop lung cancer than if you don't. The problem with just saying that, making that blanket statement, maybe we should screen more COPDers, is if you're for example, gold class 1 and 2, you might do a lot better from a competing risk of death than a gold class 3 or 4. So something to keep in mind. I'll show you some data from ours. So this is, all the participants in the NLST were asymptomatic and healthy. And I feel like you have to balance the competing causes of death from other causes with the risk of dying of lung cancer. And so this is hard conceptually to get your arms around. And I'll just show you some data from our lab. This was what we did was I saw that data on elderly patients, and I went, well, wait a second, man. All these people were healthy that went into the screening trial, younger, better educated. Let's look at let's see what reality looks like. And so we put together using SEER, which is the Surveillance and Epidemiology data set. It's the largest cancer registry in the United States from all over our country, different regions. And Medicare is all of our patients who are 65 years and older. So I combined those two data sets to ask the simple question, what if we could create a data set that looked at SEER Medicare eligible patients, that would be patients with no comorbidities, really pretty healthy who come in, and then SEER Medicare ineligible patients, those are patients who had a lot of comorbidities and would get in, and then we'd compare those to the outcomes of our NLST surgical patients. First, the good news. If you were in the SEER NLST eligible group, and we had, by the time we pare it down, got to about 4,000 patients, your 30, 60, and 90-day mortality was absolutely equivalent to the NLST data set. It's important because that suggests that this could be put out in the community safely in patients who are elderly who have no comorbidities. However, look at this. It was almost double in the group that had 2 or more comorbidities. More importantly than that, though, 73% were alive at 5 years in the NLST, 62% were alive here, and look at this, less than half were alive if they were NLST ineligible, meaning they died of other things other than lung cancer. The question is, would you ever screen this group? My answer is probably not. I don't think they'll benefit. They're not going to get the benefit from this. And this is the Kaplan-Meier curve suggesting there's a big difference in these groups. So I've kind of come up with this sort of theory, and Robert Young and I have been working on this. Low-risk patients probably don't benefit, and the harms might outweigh the benefits. This medium-risk group is very interesting to me. They have a high risk of developing lung cancer. They're still pretty healthy, so they're on this trajectory of developing lung cancer. But then something happens when they have this really high risk of lung cancer and other comorbidities, and their benefits from screening go down. How to identify that in individual patients, I'm not sure we can do yet, but I think it ought to be probably the goal of screening. I'm going to leave you with a little bit on smoking, last few slides. So everybody's quitting smoking, right? If you start after the Surgeon General report in the United States in 1963, People have been quitting smoking, and now, for the first time ever in our country, less than 20% of the adult population smokes. However, when you start to break that down among demographics in our country, it looks the slope of that decline is significantly different. So I got this idea. I went to 2 parties within 3 weeks of each other. One was a doctor party, right? Like boring, you know, everybody was inside. And I went to the door thinking, how can I get out of this party? And I looked outside, and there was a woman huddled in the corner smoking a cigarette, right? And I thought, wow, man, like, should I go out and start smoking right now? Because I'm about to kill myself. Anyway, but like, I was thinking, look how few people in this room smoke, right? And so as I thought about it, I went like, man, these people actually, all the people who have access to screening, they're wealthy, they're insured, they're smart, right? And a couple weeks later, I went to a party at my brother's house, and my brother is a laborer and a great guy, and it was a rockin' party, and you could scrape the tobacco off the ceiling, and I went to get a breath of fresh air because there was so much smoke in the room, and I looked outside, and there was one person outside trying to get fresh air who was not a smoker. And then I turned around and looked at the room, and I went, which one of these house painters, construction workers, which one of them has access to screening, right? Who even has a primary care provider that will get to it? So I published this paper in Thorax. Even before the screening trial, we interviewed 2,000 Americans, and what we found were smokers were more likely than never smokers to be male, non-white, less educated, have a poor health status, twice as likely to have a previous cancer, and unable to identify a usual source of health care. Now think about that. If you're going to a doc in the box to get sutured up for a cut, they're not going to look at you and go, oh, by the way, Mr. Silvestri, you're 55 and you're a smoker and you probably should be screened for lung cancer. But your primary care provider who's known you for 20 years, like says, hey, you know, it's time for you to get your mammography, it's time for you to get this, it's time for you to get, and oh, by the way, there's this new screening thing. So studies have shown if you can't identify a usual source of health care, you're quite unlikely to ever get screened. Smokers were also less likely to believe that early detection resulted in a good chance of cure, less likely to be willing to consider CT, and only half would have opted for surgery in this study. So the question to me was, even if the target group resides in a subgroup, the target group resides in a subgroup that has poor access to health care, less likely to want to be screened, and has a poor understanding of disease risks. And we'll need interventions. If we want to have screening be efficacious, we're going to need interventions to get these people in from underserved areas. We went on to do one other test, this would be the last 2 slides, where I started thinking about like screening is a teachable moment for smokers, right? In fact, our government requires, it's very cool, they said you have to do a smoking cessation visit if you want to screen people for lung cancer. I love it. We don't know whether, by the way, we have no idea whether it works or not, and there's a lot of studies going on. You know, the cost per quality adjusted life year for smoking cessation is pretty cheap. It's almost like getting the flu shot as compared to screening, and this was an article we published with Bill Black in the New England Journal. This was from the National Lung Screening Trial at $81,000. We wondered whether when abstinence would result in the matches that we saw from NLST. So we took the data, and well, here's what I want to show you. What we knew was this. We knew at what point in the trial, if they started the trial, had they been abstinent. So they could have quit a year before. We had that data. We also knew that if we used the chest X-ray arm, this blue arm right here, that we could get the intervention out, right? The screening intervention out. What we found was that the number of years since you quit, at about 7 years, just by quitting smoking alone, you hit the same reduction, that 20% reduction that we saw in the National Lung Screening Trial. Interestingly, if you quit and got screened, it was a 38% reduction. But just quitting alone, just telling someone, like getting someone to quit, that 7 years in, they will have received the overall benefit of the National Lung Screening Trial, which makes me believe that we've got to do better here, irrespective of what we do in screening. The last thing on the last slide, this is from the College of Chest Physicians and the American Thoracic Society, and this is our policy statement. I'm just going to show you this for 2 reasons. For the young people in the room thinking about doing research, man, having a framework for research that's right in front of me all the time is pretty good. And these are the 9 components for sort of how we look at screening. Who should be offered? You have to have a shared decision-making visit. How often and for how long? How is the CAT scan performed? Remember, it's a low-dose CT. How do lung nodules get identified? How do we do structured reporting? How do we manage nodules? How do we provide smoking cessation? How do we provide patient and provider education, and what data collection instrument are we going to use? These are all fantastic things, and if you're going to develop a lung cancer screening program in your institution, I would say two things. One is follow this algorithm, but two is do not do it alone. Do not be a pulmonologist that does this alone. This requires institutional support or it will fall apart. Even if it's the right thing to do, it's going to require institutional support. So that ends my talk. I will say, look, we're screening. We've screened about 500 in the last year and a half to 2 years. We found 11 stage 1 lung cancers and resected those, so pretty good there. Our nodule algorithm is pretty good. We've gotten a bunch of people to quit smoking. So overall, I would say our program's a success, but we have followed strictly all the guidelines I set before you. I'd really like to thank our organizing committee for having me, and thank you very much for your kind attention.